delivery. It causes 10% of prolonged neonatal hypotonia. So again, it should be at the top of everybody's list, and clinicians should be sending off a DNA methylation analysis on virtually every hypotonic baby if they don't have another reason like sepsis or etc. There's lethargy and poor arousal, weak cry, and lack of interest in food as a neonate, and it's very striking. It's just not that they're hypotonic and flappy. They really do not show an interest in feeding. And the hypotonia gradually improves, but it rarely returns to normal. And it's central in origin. A lot of the children, particularly older ones that I see, have this telltale scar on their thigh from a muscle biopsy. But muscle biopsies are non-informative, and we would prefer people do the DNA methylation test before doing a muscle biopsy if they don't know the etiology. So what are the consequences of hypotonia? There's poor sucking causes poor intake and failure to thrive unless there's assisted feeding, increased incidence of congenital hip dysplasia, delayed motor development, strabismus, lazy eye, and then later in childhood and adulthood, decreased muscle mass, altered body composition, and many have scoliosis or kyphosis. The treatment for hypotonia is supportive, no tested medication for hypotonia. We've started to use in a lot of our neonates coenzyme Q10 at 50 milligrams per day and L-carnitine 50 mg per kg per day, divided twice or 3 times a day. Some people use fish oil. Growth hormone definitely helps improve the tone, so we try to start that as early as possible, like about a month of life, if we can work out all the insurance issues. It's a little bit complicated in the States with insurance. You have to compensate for the poor suck, otherwise there'll be failure to thrive and die. So almost virtually all, with rare exception, need some sort of assisted feeding, usually a nasogastric tube, special nipples. We try to avoid putting in a G-tube because we know that it'll get better. Sometimes we have to fight with our neonatal intensivist who want to get the kid out of the NICU and just want to put a tube in and get him out, but we really stand pretty hard on that, and we've got 2 good feeding specialists for the neonates in the University of Florida. So we typically avoid that. There's rare exceptions if the child is just very flappy and it's been going on for a couple of months. And this failure to thrive phase is variable, but it can last several months, can be up to 9 months. And we follow the weight gain and growth closely. PT and OT are important. Get them involved early. Check for hip dysplasia. Monitor for scoliosis. And in particularly the deletion patients, and we'll talk a bit about the molecular classes, but can be typically a frequent look, what geneticists call a gestalt. Before growth hormone will change that, but typically untreated individuals will have a narrow bifrontal diameter. Let's see if I can get this. Is this working? Yep. So you can see the narrow bifrontal diameter in these 2 individuals. And frequently almond-shaped eyes, downturned mouth, thin upper vermilion border of the lip, and the deletions are much more characteristic than the UPDs, uniparental disomies, and the imprinting defects. There's narrow hands and tapering fingers, and there's an absence of the thenar bulge here. They have a straight ulnar border. And the hand is typically small if untreated with growth hormone. Growth hormone will normalize the hand length, but it won't normalize, it won't normalize this width here of the hand. You can see a characteristic adolescent's hand, and then you can see this hand for comparison. The hypogonadism in Prader-Willi syndrome is variable in both sexes. Typically, the males have undescended testicles, a small penis, and hypoplastic scrotal sac. And that's very helpful in terms of diagnosing an individual. So an individual a neonate that's hypotonic, floppy, poor feeder, and then has hypogonadism, there's a very high probability that individual has Prader-Willi syndrome. But again, the recommendations from our advisory board are that any hypotonic, floppy kid without a diagnosis should have the DNA methylation analysis, and we'll talk about that test more. Now, very interestingly, the females have a hypoplastic labia majora, typically minor, and clitoris. However, this is frequently overlooked, and we see a lot of children at University of Florida coming from St. Elsewhere, and they've been seen by an endocrinologist, and they've labeled the female genitalia as normal, but it's not normal. You can see here's a 20-month-old that I have with Prader-Willi syndrome. She's very hypoplastic in the labia majora, in contrast to her sister, who's 9 months old, and has a very plump labia majora. And again, these are diagnostic clues that really, before the tests come back, can kind of help you narrow down the diagnosis of Prader-Willi. But again, the endocrinologists are frequently looking for ambiguous genitalia or a phallus or whatnot. So it's frequently overlooked in the females. So hypogonadism and Prader-Willi syndrome, and others will talk a bit more about this. Pubertal insufficiency, frequently a number, 15 to 20%, have premature adrenarche, and they may start developing pubic hair at an early age, but not necessarily go into full puberty. There's delayed and incomplete puberty, a really lack of developing secondary sexual characteristics, and low sex hormones, testosterone, and estrogen. And males will lack a masculine body habitus. The sex drive is reduced, but if you give testosterone, it will increase it. I have several individuals that their interest definitely increased after starting testosterone. And the females have delayed onset of periods, sometimes up to 30 years of age, and many of them have a light period menstrual cycle or no menstrual cycle. And most individuals are infertile. There are 5 females that have been known to have offspring. And if they're a deletion patient with Prader-Willi syndrome, a female, they have a 50% chance of having a child with Angelman syndrome. We'll talk maybe more about Angelman later. So what's the treatment? Same as the general population. You bring the testes down at an early age, and their hormonal replacement for the secondary sexual characteristics. So early childhood obesity, that's one of the big problems, if not the biggest problem, in Prader-Willi syndrome. It's the major cause of mortality and morbidity. There are 7 nutritional phases my group has described from a multi-center study, and we'll talk more about that in my next talk. But it starts off, these children aren't really interested in feeding. When you talk to the mothers that have had several children before the individual with Prader-Willi, there's just not the interest, not crying up, waking, fussing about food. The appetite normalizes, and then the increased appetite kicks in several years down the way, and I'll talk more about that. And then, interestingly, we and Elizabeth Dyken have shown that some of the adults lose the really aggressive appetite drive and lack of satiety, but not all, and I'll discuss that more. So this is a growth curve that Merlin Butler did in the early 90s, and we've subsequently done it again in our rare disease study, but the solid lines show the Prader-Willi growth if you're not treated with growth hormone, and then the dotted lines are the percentiles, 50th and 95th percentile for typically developing children. So without growth hormone, there's short stature for the families. Males are about 155 centimeters, females 148 without growth hormone. Now, the evidence for growth hormone deficiency is quite strong. Short stature for the families, It results in poor muscle mass, along with, in the males, lack of testosterone, altered body composition, increased osteopenia and osteoporosis, low energy expenditures, and low IGF-1 and low growth hormone response to stimulation. So growth hormone stimulates IGF-1, and then IGF-1 does the action, and some of the later speakers will talk more about that. Growth hormone replacement in Prader-Willi, many placebo-controlled studies demonstrated the efficacy, and it was important to have the placebo controls, those that were just given saline injection rather than growth hormone, to compare the two groups. So there's increased growth velocity. I'm sure this group is very familiar with all this. Large increase in IGF-1 and stature. Now a lot of these children that would only be 5 feet taller, sometimes over 6 feet tall, and I'm looking up to them. Improved body composition, increased energy expenditure, improved motor milestones. We've noticed a big difference if we start really early at a month of age in terms of age to crawl, to walk, to sit. Better body shape. And there's been some suggestion, I don't think it's conclusive, but some people have suggested there may be better cognitive abilities than untreated. Certainly in terms of the motor milestones, it's been definitely increased. And then Sue Myers and Barb Whitman and many others have shown that, the Dutch group as well. So the first reported use of growth hormone in Prader-Willi syndrome was Philip Lee in 1987, but it wasn't in the United States approved by the Federal Drug Administration until 2000. And that was because there weren't good placebo-controlled studies up until the late 90s, finally published at the end of 90s, early 2000s. And recently, Sherry Deal convened a consensus workshop up in Montreal and got together guidelines for Prader-Willi syndrome. It's now considered the standard of care in childhood. Studies have shown efficacy starting at 4 months of age, but really no age is too young to start. So, we've started as early as a month of age, but the studies go down to 4 months. The benefit of low-dose treatment in adults for body composition, alertness, and sense of well-being has been demonstrated by several groups, particularly Charlotte Hoiby in Sweden. So this is a very powerful picture that Maurice Angulo sent me back in the 90s, the mid-90s, and he published in the American Journal of Medical Genetics. And here's an individual that he treated over, I think it was 2 years' time, 6-month intervals. He got these pictures. And of course, growth hormone's not a diet prescription, by the way. It helps, increases the muscle mass, increases energy expenditure, but you don't do it in place of dieting as well, controlling the food intake. But with a well-controlled food intake, exercise, and growth hormone treatment, you can see the remarkable difference in this individual. And so I approached my endocrinologist at University of Florida in 1995, and I said, "This is great, let's use this." Well, they wouldn't start it. There were no placebo-controlled studies. Many endocrinologists didn't buy into it. I was able to get some endocrinologists to start in the 90s in Miami and Orlando. But again, the ones at my institution wouldn't until Jennifer Miller came and worked with me, did a postdoctoral fellowship, and then we started doing it at University of Florida shortly after the FDA approved it for use. But the key thing here is that it wasn't well accepted until there were placebo-controlled studies to show that it was safe. It wasn't increasing the diabetes, it wasn't increasing or worsening the scoliosis, etc. And so that's a real lesson. And many people maybe have participated in clinical trials and wonder why you need a placebo-control group, but they're actually very important. And we run a lot of clinical trials at University of Florida, and I've seen a big effect from just the placebo. The people really believing and thinking this is going to work, and swearing it works, but they got the placebo. So Just a word of note to those that wonder why they have to participate in a placebo-controlled study. And I think other speakers will talk more perhaps about that. So here are two brothers I have, and so which one has Prader-Willi syndrome? Yeah, the one with light pigmentation, and the old G-tube scar. Whoops. But you can see the really normal faces, and he's actually leaner than his typically developing brother, who's a year younger than him. He has 20% body fat by DEXA, and the brother has 20%. So 24 for the Prader-Willi, 20 for the Prader-Willi, 24 for the brother. I get it. So growth hormone replacement, potential problems brought up by the consensus group. Hypothetical increase in relative size of adenoids and tonsils could worsen the obstructive sleep apnea and cause death. And this was first postulated by Martin Retson at the end of the 90s, 2000. And those of you that know Martin know what a great clinician he was. So we recommend a sleep study before and after starting growth hormone. Some of the children we have to stop and take the adenoids and tonsils out and proceed. So other problems, if you give too much, you get acromegalic coarsening facial features. And then there's several recommended exclusion criteria, including severe obesity, uncontrolled diabetes, obstructive sleep apnea, active cancer, and active psychosis. And here are some hands of one of my Prader-Willi patients that's been treated by another endocrinologist, not Dr. Miller, but has arachnodactyly, has developing morphinoid features, and he got too much growth hormone, starting a coarsening of the facial features with a prominent chin prognathism, and head circumference, where the head circumference is much larger percentile-wise than the rest of the family. That's a problem. So other hormonal problems going to be covered in more depth by other speakers. Hypothyroidism, central adrenal insufficiency. The Dutch group years ago said 60% had central adrenal insufficiency. We don't see it that high. I just had a meeting of my clinical and scientific advisory board, the international group, and everybody agreed that this is very low. Some people have 0, some 1 or 2%, but the 60% was way too high, and it probably related to the agent they used to stimulate for the test. So developmental and intellectual disability, I think most of you are pretty familiar with this, and James has given me the sign to wrap it up in a bit. So I'm going to hasten the pace here, but motor and language development, IQ in the 60s. Many adults can read and do simple arithmetic. Some are actually going to college and are actually have pretty IQs in the high 90s, maybe even getting over a little over 100, but they need supervision. One of the parents sits outside the classroom to make sure the child doesn't go to the vending machine or get food. So if we could control the hyperphagia, that would really lead to a lot of independence of some of our higher functioning individuals. So the behavioral phenotype, Stuart Einfeld will talk more about that, so I'm going to move on. Other nervous system abnormalities, high vomiting threshold, high pain threshold, decreased saliva flow, skin picking at about 50%, sometimes rectal picking, and some have an altered temperature regulation, increased risk for seizures about 10 or 20%, but they're not hard to control seizures like Angelman syndrome. Sleep abnormalities, common in many, especially excessive daytime sleepiness, and modafinil or Provigil is helpful with that. Some people are using pitolisant, and recommend a sleep study for all. Pathophysiology, many manifestations of Prader-Willi relate to the hypothalamic dysfunction, but there's been no definitive biological abnormality identified. We think we're honing it down on some things, but a lot is known about the genetics. So I started in genetics in the 70s. I'm getting the signal, the subtle signal. started in the 70s in genetics, and Merlin Butler and I overlapped in graduate school at Indiana. And he showed, first David Ledbetter showed 1981 a deletion in some. Merlin Butler showed in the early 80s that it was the deletion always came from the dad when they could see it by high-resolution chromosomes. High-resolution chromosomes only picked up 50% of the Prader-Willis. We'll talk more about that. So here's the Prader-Willi region on chromosome 15. It's about 5 to 6 million base pairs. Really, the heart of it is the 2 to 3 million base pairs where you see the light blue and then the orange. The light blue genes are only paternally expressed. The genes in orange are only maternally expressed. So that's why Angelman and Prader-Willi have the same deletion, but it's the parent of origin. A small percentage of our genes are only expressed coming from either the maternal or paternal contribution. Most don't care, they're Mendelian, but a few percent do. And so out of 20,000 genes, you have a couple of hundred that really care which parent they came from. So if you have a deletion on the maternal chromosome, it's going to be Angelman. If it's a deletion on the paternal, it's going to be Prader-Willi. And the two most common deletion sizes are the type 2 and the type 1, and there's various breakpoint regions here. So we talked about this. It's the paternal contribution that's missing by several different mechanisms we'll talk about. Angelman is due to the loss through 5 different ways of UBE3A, 4 of which we know, 1 of which we don't know. But we know all the ways Prader-Willi comes about. So this is just a cartoon of showing the blue paternal contribution, the pink maternal, and 70% or so have a deletion on the dad's chromosome. There's one problem using this mouse here. The UPDs have 2 contributions from mom, none from dad, and the imprinting defect has a contribution from mom and dad, but the imprint on the dad's chromosome is still maternally imprinted. And in the early 90s, my lab worked out DNA methylation analysis that would pick up virtually all Prader-Willi syndrome patients and 70 to 80% of Angelman patients by using, first we used methylation-sensitive enzymes and southern blotting, and then David Ledbetter's group came out with methylation-specific PCR. And you can see the normal contribution has both a maternal and a paternal. Angelman is only a paternal contribution, Prader-Willi only a maternal band. And this is a more rapid technique without radiation, but it's not as precise as the old southern blotting. It doesn't do dosing very well, and it risks, there's several other problems I don't have time to go into, but it's pretty much standard in a lot of labs. We've also shown, Sue Kim in my lab showed that about 8% of individuals with deletions are not type 1 or type 2. They're either bigger or smaller, and this just is showing 7 patients we reported a few years ago. The key thing is that sometimes the deletion size makes a difference. These 2 at the bottom, they break another 5 million base pairs down to breakpoint 5 and delete the Charner7 gene, which is involved in seizures. So these patients are very high risk of having seizures. And as a matter of fact, in one of the patients, it was unrecognized, the petite mal seizures she was having. People just thought, the teachers thought she was just disinterested, but she was seizing, and that's why she looked bored in class at times. Mechanisms causing UPD, just briefly, it's a non-disjunction, typically during meiosis 1 of the mom's oogenesis. It's initially typically start with trisomy 15 and then a reduction to 2 15s. And this was first shown by Susie Cassidy. There was a mother that had a chorionic villus sampling at about 8 to 10 weeks pregnancy. It showed a trisomy 15, and people went, whoa. And then they did an amniocentesis like 6 or 8 weeks later, and there was only 2 15s, and people said, great. And then the child was born with hypotonia, characteristic features of Prader-Willi, and the individual had Prader-Willi by UPD. So there's various other mechanisms. There's 3 types of uniparental disomy. I don't have time to go into them, but I'll just briefly mention segmental isodisomy, heterodisomy, and complete isodisomy. And it does make a difference. I also, just recently, Jen Miller referred me a patient with ambiguous genitalia, and they had, this individual has mosaic trisomy 15 and maternal UPD 15. So 16% of the cells have still 3 15s, didn't lose that 15 in early embryogenesis. And then the one the child lost was from the dad, so it's a UPD. And many more characteristics than Prader-Willi syndrome. Ambiguous genitalia. This is a male, but there's no scrotal sac. The gonads are intra-abdominally. Growth failure, developmental delay, dysmorphic facial features, heart defects, pectus excavatum, and hemihypertrophy, different length of arms and legs and the ear on one side versus the other. And I heard in Australia there's another family that has a mosaic trisomy 15. So we can talk more about that. So imprinting defect. We first, in the early 90s, my graduate student Chris Glenn in my lab showed that there was a third mechanism besides deletions and UPDs in Angelman and Prader-Willi. We had 2 kids with Angelman syndrome that Charlie Williams had diagnosed. And when we looked, there was biparental inheritance, but by DNA methylation analysis, it was Angelman. So and then subsequently the German group showed it was also occurred in Prader-Willi. Most are epigenetic, i.e. sporadic. 10 to 15% are due to a microdeletion in the imprinting center, and it's important to find those because there could be a 50% recurrence risk if the father is a silent carrier. So genotype-phenotype correlations. The genotype doesn't predict the phenotype in an individual. As a group, there are certain patterns, but you can't tell right at birth how severe or how mild things are going to be just by the genotype. Although if they have a big deletion, then you know that there's a big seizure risk. So more common in UPD is a slightly higher verbal IQ, greater frequency of autistic spectrum features, and greater frequency of psychosis. More common in the deletion is the light pigmentation, because the deletion takes, in both Angelman and Prader-Willi, takes out a pigment gene, OCA2, that if you miss both copies of the OCA2 gene, you're an albino. If you're missing one copy, you're lightly pigmented for the family. Characteristic facial features, seizures, skill with jigsaw puzzles. And so I'm going to pretty much skip over this. The punchline is imprinting defects need to be worked up, and if there's a microdeletion, there's a 50% recurrence risk. Prenatal diagnosis, we showed at the end of the 90s, and David Ledbetter did as well. DNA methylation can work. It can pick up all 3 types, but it has to be done in a very special lab, and it can be a little tricky with chorionic villus sampling because it's a hypomethylated tissue. Meanwhile, FISH analysis, chromosomal microarray, will pick up the deletions. So the DNA methylation picks up all types, but it doesn't tell you what type. So then once you find out it's Prader-Willi, and you can, there are some labs doing this from a blood spot, doing DNA methylation analysis. The Bird Institute in Italy that does free testing for IPSA, the international group. So it's very good, but then you need to figure out which type, because it could influence the recurrence risk and some other risks. The chromosomal microarray will show the deletion size, and UPD studies need to either be done with both parents and the child by DNA polymorphisms, or if you do an oligo SNP array, it'll pick up 70% of the UPDs. It will not pick up the subclass of heterodisomy. So what have I learned? Actually, it's been about 40 years, Jim. James, you underestimated my age. So early diagnosis makes a huge difference. You begin anticipatory guidance. For instance, back in the 80s when I was training at Johns Hopkins in genetics, we would typically make the diagnosis about 5 or 6 years of age in deletions, maybe 10 or 12 in UPDs. But by then the child was very obese, had gotten bad habits, had an insatiable appetite. So the earlier you can do it, you can tell the family what to expect. Yes, the child's failure to thrive now, But beginning at 18 to 24 months, the weight's going to start to go up, and then you need to start cutting back. Starting growth hormone early makes a big difference, and I think one of the next speakers is going to talk about that more. Genotype cannot predict the severity. The ability of families to set limits early improves behavior. Getting into good habits before the appetite control is an issue, and I always say the Prader-Willi diet is a diet that all people, especially Americans, should be on. It's actually a very good diet. Low and simple carbohydrates, lots of fruits and vegetables. Education and support of families improves the outcome. The patient advocacy groups, and I'm very involved in the U.S. one and the international one, make a huge difference. I mean, it's the networking, it's the support. Being a geneticist, it's really impressive to me how these groups are very important for support, and it impresses me how families can really come up to speed and pick up the challenge. And I'm optimistic about many of the ongoing clinical trials. Other speakers will talk more about that. But I do want to emphasize the blinded placebo-controlled studies are crucial. Jen Miller and I just did a study, and Jen was trying to predict who was getting the drug and who wasn't. And she wasn't always right because the placebo group was improving. Well, we had a feeding therapist working with them too, and that was helping a lot. So you really need the placebo group. And I don't think one medication is going to do it. I think it's going to be a combination of medications for the behavior, the hyperphagia, the lack of satiety. So this is my lab and clinical trials group. Jen Miller's missing from this picture. She's been my close colleague for the last 20 years. And I do want to mention that we have an international meeting coming up in 2019, November, in Havana, Cuba. We hope everybody can try to make it. So I'm done. You can stop the hand signals now. So questions later, or is that how we're doing it? Thanks.
Thank you very much.